Dear colleagues, as always, you're most welcome. Time flies by. We are deep in August. I would like to entertain you with a very current picture. A few days ago, there was this wonderful event, the solar eclipse. It was very well visible in Spain mostly. Dear colleagues, in your place, in my place, all over the world, most of the breast cancers originating from the TDLU, and their imaging biomarker is either stellate or a microlobulated ill-defined circular lesion. The radiologist's job to detect it when it is small. Don't believe that all of them are the same. This is what I did with the help of a pathologist with their written report, as well as looking at the histology, as well as asking my trusted pathologist friends. So we know that this is the good, this is the not so bad, but this is a real ugly. And you remember these numbers. By looking at a mammogram, we cannot distinguish. That's why they are the same mammograms here. So we need at least a core biopsy, or preferably microscopic examination. Why is it so important? Why am I working so hard on this? Because therapy today is practically the same. Tamoxifen, a little bit chemotherapy, a little bit radiation, and that's certainly wrong. And we have been preaching about this for decades now. It's just about time to reinforce what we know. These patients are heavily overtreated if they get radiation. And mind you, that's about 53% of all these small cancers. We talked about the suggestion. Why don't we talk with the surgeon, take this out with good margin, a centimeter or so, talk with the pathologist, use the mega cassette, then we can see that there are no satellites or in situ. In that case, these many women should not get irradiated, but get back to the yearly surveillance, and extremely few, less than 10 out of 100, is going to get recurrence in 10 years. It's an enormous amount of money and pain and side effects and everything. Don't overtreat. At the same time, I'm pushing this distinction between the good and the bad and the ugly because this one is not cured, not as much as this. This is a surgical disease, and look at the outcome, 98%. Neither the surgeon nor the oncologist can bring this curve up here. There are two messages here. Cut back on overtreatment. Analyze this down to the genes and the cellular level, because we don't want to have these women die to this extent. They actually die. Nothing new about this. Look here. 2011. That was about 15 years ago. When our research group came up with this idea, we collected 425 baby stellate lesions. And then we asked our question, what is the benefit of radiotherapy? Mind you, that was 15 years ago. Because there are the side effects and all kinds of risks, and it's not fun. So patients with stellate tumors of this size have a good prognosis. We used the Cox regression method and followed these women for a long time. Here we are. Our observations suggest that the only group of this size benefit from radiotherapy who are 55 plus, high grade, poorly differentiated, and non-lobular. Lobular doesn't benefit from it. Younger women don't. So in these certain groups, we could separate which benefit and which doesn't. Younger women or women with lobular carcinoma, of course, they don't benefit, and our pure AABs don't benefit. There are 4 curves here. This one and the yellow indistinguishable. Those are the 1 to 9 millimeter radiated, not radiated, indistinguishable. 10 to 14 millimeter, the purple and the blue, indistinguishable. Dear colleagues, this we put out 15 years ago. Nobody listens. Poor women, older women with their very fragile and thin chest wall, with the heart under it. This is what we are talking about. So that's the introduction to this lecture. Could anybody, based on these and based on the upcoming results we are going to put out based on close to 1,000 cases, wake up and say, it's a 4 by 4 millimeter stellate lesion. And when you look at the histology, it's not the ugly, it's not the bad, it's the pure AAB. Why don't you just follow her up? You are going to do the self-polling. I show the story, the age. On her mammogram, you are going to find out where there is an asymmetric density. Interesting. Age 69. Why does she have so much tissue? Is this pattern 4, adenosis pattern? Or has she taken HRT for decades? Anyway, you look at these mammograms this way, and you scratch your head. AI doesn't help because it's going to point out the very obvious thing here. Now you understand the cancer is not going to be there, and the cancer is not visible or detectable at this time point. That's her previous examination. So we are doing this side-by-side, step-by-step viewing. If you squint, you see how very nice the no man's land is. And look at the contour, because that's what we learn in school. If it's dense, we have to look for bulge out or retraction. No, there wasn't anything. AI just points out that little one. Radiologists are correct and the AI is correct. I want to call your attention that AI also made a very shy mark there. Interesting. Let's go to the next one 2 years later. This is going to turn out to be benign fibroadenoma later on. Didn't change, why should it? And so now we are looking at the medial half, the no man's land. Let's do it. Do you find something else than that little bump in the retroareolar area in the left breast? The axilla is fine. Now you should look at, you see the no man's land? There is something very interesting there, is it? Did you pick it up? There was a so-called tent sign. Medial half is okay. AI picks it up, and of course it was picked up. It's very vague on this picture, kind of architectural distortion, but this is what we call the tent sign. Parenchymal contour retraction. And ultrasound says, you're absolutely right, this is malignant. You put the needle in, and now comes the self-test. I'm going to show you the histology after mastectomy. Why did she need mastectomy? Patient's preference. The pathologist marks only a part of this triangle-shaped density, rightly so, because this is only fibrosis. So only a fraction of this, kind of an iceberg phenomenon, is cancer here. The rest would be fibrosis. Let's go on. No, I still don't ask you to do the self-test, but after this, is this a good? Is this the bad? Is this the ugly? You're absolutely right. We tested and tested this again and again. These are the acini. This is acinar adenocarcinoma of the breast. Well differentiated. Here is one more group. And this is a unifocal, well differentiated AAB, the good. You can figure out what the immunohistochemical biomarkers are going to be. That is ERPR positive, HER2 negative, E-Caterin, of course, positive, extremely low Ki67, and no node positivity. After all these, we ask our question, what's going to be the long-term outcome? She already survived more than 10 years. She is walking on this very horizontal curve. That's the benefit of finding these cancers early, before their cells differentiate. And indeed, 10 years, 1 month, she's well. That was case number 1, and I'm sure you did a very good polling. I'm trying to be up to date. This was happening last week. I don't know whether you went out. It must have been quite an experience. Dear colleague, she is 73. Call back from mammography screening to assess the finding in the upper outer quadrant of the right breast, not at this time point. Well positioned, huge, totally fatty replaced breast. I look at the axilla. Well positioned, I see a bit of the pectoral major muscle. The nipples are in profile. AI says, you are absolutely correct. And it's not going to be a rocket science when concerning perception, because next time, 22 months later, out of the blue, out of nowhere, this comes asymmetric density, convex contour, de novo, go for it. AI says go for it. Not only the solar eclipse happened last week, but also there were the stars falling. You might have watched them. Is there anything in the tail? Maybe, may not be. We go for this, do the core biopsy, and here's the core biopsy. One shot is enough for you to make a very educated guess. I help you. Is this what we are talking about? Is this one? Or this one? It came fast. We don't know when it developed. I give you more. I don't think there is anybody who believes that this is an acinus empty in the middle, lined by cancer cells. We do MR. It's very difficult to place her into MR because of the discrepancy between the size of the hole and the size of the breast. But anyway, nothing in the left breast, washout effect in the right breast, and already at this time point, you should say, is there any rim enhancement? We'll see later on. Good surgery? I would prefer a little bit wider tissue around, because you never know whether there are non-calcified satellites or DAB. Seem to be not. We are going to explain what these actually are. Dear colleagues, already at this time point, I would expect that you are going to answer the question. Here's a video that is going to help you. Is this the good, the bad, or the ugly? Let's measure it. It's 13 millimeter by 9 millimeter. 13 by 9. We remember the mammogram. It was extremely small. I don't want to say that this is pathognomonic, that is the desert in the middle, as fibrosis. Sometimes we see it in BCMO as well, but you should take it as pathognomonic. That is, the desert is surrounded by enormous amount of very poorly differentiated cells. You see those dark dots, the mitosis, tons of them, large nuclei, nucleoli. Look at this group, for example. And when you unzoom, then you see that these clones are in groups. The radiologist described very correctly microlobulated. The cancer is growing here, but this is fibrosis. So there is a ditch here, so to speak, and it grows here, and it grows here. So then I want to answer a question. Why is it ill-defined? There are two options. This is superimposition of fibrosis. But here, the cancer cells are very diligent in marching out to among the fat cells to the interstitial space. That would be the other option. We have a very good grip on this. This cannot be the good. It must be the ugly. You have seen these very, very unpleasant cells. And because it measured only 13 by 9 millimeter, I cannot use the word neoductgenesis. It has to be neoacinogenesis, of which these cancer cells came out. Immunohistochemical biomarkers, it doesn't excite me anymore because I know that it's bad and bad and bad. And then it tells me it's ER positive, PR positive. What do you want to say? This one I like. Somebody says that it's going out of fashion. No, I don't think so. I really like the proliferation index. E-cadherin positive, of course. We have here a unifocal 13 by 9 millimeter de-differentiated neoacinogenesis. Is it a good news that there is no LVI? There is no node positivity? People believe that basal-like is the worst kind of carcinoma. Well, this is not basal-like. Let's see what's going to happen. She diligently comes back to follow-up examinations. She's riding on this one. Isn't that shocking that she's happy after 7 follow-up examinations? But, and the 8th year, high up in the axillary tail, so high up that the invasive, newly developed carcinoma grabbed one of the lymph nodes and infiltrated directly. Look how angry the cells are. And this one as well has the desert in the middle. Here are the very angry cancer cells in bundles, neoacinogenesis. So it recurred. Why? This is the metastasis in the lymph node, but it breaks itself through the capsule. This is the extranodal carcinoma. That's de-differentiated, like this, in the interstitial space. Don't like it. As long as we thought it was LVI negative and it was node negative and it was not basal-like, we were hopeful. But you see, this is exactly the problem with this kind of cancer we call de-differentiated neoacino or neoductgenesis. The 3-step procedure. 6 nodes are positive. You can admire again the ER positive, PR positive, HER2 negative. This one tells me something. So 8 years pass by, and it's huge. Should we call recurrence? No, I don't think it's recurrence. I really believe that this is the typical stem cell carcinoma that you start to revisit. I show you the literature as I already showed it, but it's not enough with that. 8 years passed by, she got this terrible new carcinoma. And another 3 years passed by, and she got liver metastasis. And at this time, you know how to evaluate. This is the normal liver, and this is the cancerous liver tissue. Normal and the cancerous. Same cancer. What was the size? 13 by 9 millimeter. Solitary, unifocal. Here is the liver metastasis. All these immunohistochemical biomarkers. GATA positive, estrogen receptor positive, and GATA positive that really comes from the breast. And the sad thing is that 11 years and 6 months after diagnosis and initiation treatment, the patient didn't die from the simple term breast cancer. That's what the relatives are saying. Professionals are saying, what is the redefined assessment of the metastasis? Give me the core of the liver metastasis and analyze it, partly using the histology. It's very identical or very similar to the original cancer, and partly the immune histochemical biomarkers. So there is no doubt that she died from the dedifferentiated neoacidogenesis. Dear colleagues, case number 1 I showed you today is going to get tamoxifen, is going to get radiation and whatnot. This patient got the radiation, got the chemo, still died. That's my main issue in these courses. Why did it recur? I showed this to you, and I'm going to recall your attention to this article from New Zealand. We are in the 21st century. Half of the fatal cancers originate from the major lactiferous duct or from the mesenchymal pluripotent hybrid stem cells. The old-fashioned way of thinking is not working anymore. The previous model has been overridden with this new way of thinking about cancer stem cells. This explained to you why this patient was supposed to be cured from this 13 by 9 millimeter cancer. 8 years later, and in the liver, got renewal, invasion, metastases. That's the new way of thinking. In DAB and in BCMO, don't think the old-fashioned way. Or in the small stellate and some of the circular lesions, mostly the stellate, sure, you might. The stem cell carcinoma can go to sleep, as in this case, for 8 years. Here is the word self-renew, differentiate, laughs at chemo and radiation, and initiate new tumors upon serial transplantation. I showed you 2 very different cases. This group is willing to hang in with me. You are going to learn new way of thinking.